Good afternoon. On behalf of the Department of Medical Oncology, I welcome you all for this today's combined round. Most of us and most of the lay people know about the toxicity because of the chemotherapy, which we use day in and day out. However, more and more of people are realizing another important toxicity of the chemotherapy, which is the financial toxicity, and more people are started talking about this thing in the public fora and also in scientific meeting and also. So probably there are some ways which we have tried to take out and see without losing the efficacy of the drugs, whether we how best we can use the smaller dose, low dose without affecting the efficacy. And one such case is being presented today. So my colleague Dr. Ranjit Sahu and Kanupriya will present and discuss the case. Over to Ranjit.
Uh, Thank you, sir, for that kind introduction. And I will request Dr. Kanupriya to start with the case.
Good afternoon, everyone. I would be talking on the toxic cost of cancer. So beginning with my case, I'm presenting the case of a 70-year-old male, Mr. J, who presented with lower urinary tract symptoms of frequency and urgency in November of 2014. His baseline PSA was 1120 nanogram per milliliter. He underwent a transrectal ultrasound-guided prostatic biopsy, which was suggestive of a prostatic adenocarcinoma, Gleason score 4+4. Just to briefly tell, the first numeric value 4 is the most common histological grade that is seen on the biopsy, and the second numerical value is the worst histological grade that is seen, making it a total score of 8, which is a grade group of 4, suggesting that the rate of cancer growth in this patient was extremely fast. A baseline PSMA PET scan was done, which showed avidity in the prostatic primary, pelvic and retroperitoneal lymph nodes, and multiple other bony metastases. So in this patient of castration-sensitive prostate cancer, we managed, and the patient underwent a bilateral orchiectomy in the January of 2015 and was started subsequently on bicalutamide 50 mg per day. He had symptomatic recovery, and the PSA dropped to a nadir of 0.24 in the August of 2016, but then gradually started to increase to a level of 3.02 after 1 year, though the patient remained asymptomatic at this point of time. So once the PSA was increasing, the patient underwent a PSMA scan again, and here we can see the images which show that the avidity was there in the prostatic primary, and there were low volume bony metastases as well. So just a graph of the PSA level after bilateral orchiectomy and starting on bicalutamide, the PSA levels were 22 to begin with, which on bicalutamide decreased to a nadir of 0.35, but then again started to increase till August 2017 when they reached a level of 3.02 when we started the patient on abiraterone acetate. So the patient had an androgen deprivation therapy interval of nearly 2 years, suggesting that he had a hormone sensitive disease. But now he required further androgen inhibition for the androgen that was probably coming from the adrenal glands, which is why we started on abiraterone. Abiraterone is a selective, irreversible, potent inhibitor of CYP17 alpha hydroxylase, which prevents the formation of androgens from the adrenal gland. It comes in a formulation of a tablet of 250 mg, and the dose which is recommended is 1000 mg once a day, empty stomach. So these are the Kaplan-Meier curves of the landmark trial in abiraterone acetate in metastatic castrate-resistant prostate cancer, where we can see that addition of abiraterone acetate significantly improves the progression-free survival and the overall survival over placebo. So we started the patient and we saw that the PSA had declined from 4.33 to 0.08. But at this time, the patient came to the clinic and was significantly distressed. So what do we do in these scenarios where the situation is such that the disease is responding, but the patient is in distress because of financial toxicity? So to understand this, we need to go back to our basics of pharmacology. So understanding the pharmacokinetics of abiraterone, when abiraterone was approved, the patients they were given this drug in a fasting state at a dose of 1000 mg per once a day, which is why the recommendations are so. But subsequently, many studies have seen that the plasma level of abiraterone is actually more if it is given in a fed state. So these are the graphs which show this. The highest line is actually the plasma levels when abiraterone 1000 mg was given in a fed state with high fat meal, followed by a low fat meal, and the least levels are seen when it is given empty stomach. So based on this limited knowledge that we had at that time, we started the patient on abiraterone at 250 mg per day, hoping that decreasing the dose by 1/4 would actually decrease the financial burden of the patient by 1/4, keeping probably the plasma concentration of the drug same with low fat meal. And here we can see the the prostate specific antigen levels, which in 2017 reached around 0.05 and are stable around 0.04 as of July this year. However, the patient has significantly, his financial toxicity has improved, wherein the cost of the drug has decreased from nearly 30 to 40,000 to 5,000 per month. So to understand this further, a collaborative effort was made by the Department of Medical Oncology and the Pharma Department of AIIMS in a study which was funded by AIIMS to study the food-enhanced pharmacokinetics of low-dose abiraterone acetate in metastatic castrate-resistant prostate cancer. The study was conducted by Dr. Meenakshi Meenu, and they looked at 18 patients and saw 18 patients were given abiraterone initially at a dose of 250 mg per day with low fat meal. In low fat, they were given actually 200 ml of milk, which contains 7% of fat, and plasma levels of abiraterone were seen at 1 hour, 2 hour, 3 and 6 hours. And after 6 days of such dosing, a washout period was given, and again the standard dose of abiraterone was given to the patient, which is 1000 mg in a fasting state. And what we analyzed was that actually the higher curve is of 250 mg abiraterone, which was with milk, showing that the plasma levels of abiraterone are actually higher when taken with milk at a low dose 250 mg as compared to 1000 mg, which was given in a fasting state. Shortly after this paper was published in JCO, which again saw that giving low dose abiraterone with low fat meal at 250 mg of abiraterone dose, the mean log reduction of PSA was actually equal to the standard dose if the standard dose of abiraterone was given. There are other examples of this such scenario as well, where the interaction between food and drug has been studied. This was a study that was done in our center by Dr. Ankur Varsne, and he saw that nilotinib, which is a second generation TKI used in CML, at a dose of 300 mg twice a day, if it was given in a fed state, the AUC of the drug and the Cmax was actually better in a fed state as compared to the fasting state. In fact, he saw that nilotinib at 150 mg BD had actually an AUC ratio of almost twice in the fed state as compared to the fasting state. So such interactions can be seen when two drugs are given together also. This is an example of azacitidine and venetoclax, which is used in AML, either in the elderly AML or relapsed refractory setting, and has good response rate. But it comes with a very high financial burden, not only because individual drug is costly, but also in abroad it is given in a hospitalized patient. In our clinic, we have been able to decrease the cost of giving azacitidine venetoclax manifold. One, because we give it on an OPD basis, and second, we've actually been able to decrease the dose of venetoclax to almost 1/4 while giving it with azole antifungals. Azole, as most of us know, is a CYP3A4 inhibitors, and they actually increase the level of venetoclax in plasma. Similarly, lowering the dose of drugs can also help in decreasing financial toxicity for the patient. Now, ibrutinib is an oral anti-cancer drug which is used across many malignancies, especially in CLL. It is given in a dose of 420 mg once a day. A study was done and published in Blood in 2018, where they gave the first cycle in the recommended dose of 420 mg once a day, but the second cycle was given at a reduced dose of 280 mg, and the third cycle was given at a dose of 140 mg. And they saw that the receptor occupancy actually remains almost saturated, that is at 99%, even at the reduced dose of 140 mg. And the chemokines that are released, the decrease remains the same even at the reduced dose. Lesser frequent dosing of the drugs might also help. In RCC, nivolumab, which is a monoclonal antibody, is recommended at a dose of either 240 mg once in 2 weeks or 480 mg once in 1 or 2 months. This is a paper which was published in JCO again, where they saw that the dosing of nivolumab, zero point 0.3 mg per kg versus 2 versus 10 mg per kg once in 3 weeks, there was no dose relation with the PFS. So the PFS actually and the overall survival actually remains the same. Similar to this, a retrospective analysis was done of our patients who received a modified dose of nivolumab, either 100 mg dosing flat or 3 mg per kg 3 weekly in relapsed refractory Hodgkin's lymphoma. And the data showed that the 2-year PFS remains equal to the historical control in such setting at 85%. Now, I would like to invite Dr. Ranjit Sahu sir to continue with the further discussion.
Thank you, Dr. Ganu. Now, at least in that patient, we had been lucky enough. Normally, the median survival of such cases after establishment of CRPC status is close to 15 to 18 months. But with that dose, the patient is still surviving without any further lines of treatment. Now, drug development, it is not a very valid term, but it is very much convenient to be used in LMICs like India. So when we use lower than the recommended doses of approved drugs, especially in life-threatening situations like cancer, it is a controversy. But at the same time, I would say this is the need of the hour, especially in settings where the resources are limited, especially with finances. Because it would not only reduce the side effect of the doses which are recommended, which could be actually toxic to the patient, the incidence of side effects may actually increase. It can also reduce the cost of these life-saving medications manifold, and hence it would also reduce the financial burden of the patient on the patient. The second problem is there had been a lot of changes, not in oncology, but in other disciplines, which had happened over last many decades. However, the changes in the clinical trial paradigms, they just remain the same. Even as of today, I mean, we are using drug at the maximum tolerated dose or MTD, which could be toxic to these patients. And these drugs are mainly developed in the cytotoxic area. Cytotoxic are controlled poisons which were mostly given as parenteral medication, and it was always good to anticipate how much the patient can actually tolerate in the phase 1 studies. But we actually do not know what is the optimal biological dose or OBD in such cases, where beyond a certain limit, especially these newer drugs which are tyrosine kinase inhibitors like imatinib, nilotinib, even when you are increasing the doses of the drug, the effect just remains the same. And increasing the drug beyond a certain dose, it will only add to toxicity and not of any benefit. So the randomized control trials which had been done, it is mainly to compare two sort of medications. But I think this sort of dose ranging trials, I mean low doses and the recommended doses, that sort of randomized control trials are yet to be performed in clinical settings. So the other thing is the clinical perspective of labeling. When a drug has to be taken with food, or if when a drug, on the contrary, when a drug is actually to be taken empty stomach and you are taking with food and it increases the absorption, it might lead to many adverse consequences. And the relationship with food should be clearly written on the outpatient card. And I personally feel we are economically hostage to big pharma, where they are giving a higher dose of drugs. This is the scenario in the West as of today. And to determine what is the right dose for such scenarios, more clinical research should be conducted and to be supported. To conclude the presentation, I think as of today, cancer means three things: mortality, inaccessibility to treatment, and cost to the most. WHO recommends that early detection of cancer, accurate diagnosis of cancer, and access to treatment, these are the most important things to make the cancer more controllable or curable. In LMICs, like in India, the age at onset is at least a decade lower than what is happening in the West. This is not because we are a different population. We know that more than 60 years, which is a cancer causing population in the West, and as compared to in India, more than 60 years is only 9% in the last census. So our patients, they develop this problem at a lot earlier stage, at a stage when they are in their 40s or 50s. That is the age when they earn the more and they are susceptible to this sort of cost toxicity. Then comes the insurance. I'm sure that when you look into the data, the insurance coverage of our country is very, very less. It is less than 5%, which also has implication over financial toxicity. So at LMICs, the intervention should be directed to be resource sensitive and not to actually follow what is happening in the West. It will improve the accessibility and it would also reduce the cost. So research as of today in high income countries or HICs, they are mainly on the drug discoveries. But in LMIC, we should focus morely on this drug de-development and possibly drug repurposing, where we use similar drugs causing similar pathway inhibition in our scenarios. Now that will be my last word. I would thank everyone for the kind listening. I'll be answered to answer then a few questions if you have.
Basically. So for the immuno-oncology drug, like he showed once, probably each month the treatment costs close to 200 or 250,000. So if with the same result we can use with either the de-development or repurposing and this thing, we may probably will be able to cut down the cost to at least about just the 20% of what otherwise we are probably spending. So like he showed Ablatron, probably other now it's a generic is available. When it was introduced, probably cost would be around 40 to 50,000 per month, and it need to be taken for a long period of time. So with just the single drugs, instead of 1 gram, probably if you give 250 milligram with the fat meal and this thing, you will be able to cut down the cost just to 25% of that. So I think we are exploiting the pharmacokinetics to our advantage. That is the probably basic.
Replicated, and that is another such example where the 700 milligram without food was the initial approved dose based on the registration trial, and subsequent trials showed 450 milligram taken with fat meal gives you equal pharmacokinetic data and also the clinical efficacy.
Oncology that they know MPD, but the drug companies, the pharma industry probably will start with the drug trials. They will use the drug trials, do the drug trials. They will be using the maximum dose basically instead of using a lower dose, so that get the FDA approval and people will start using that. Sorry, Dr. Dev.
Yeah. I'm sorry, I joined late. Basically, the most of the RCTs and evidence in the oncology field, as you said, are resource neutral. They don't address the resource part. So NCCN, I think in the last 5 years, they are working on resource-based treatment guidelines. So stratification of country according to WHO classification and recommending certain treatments which are feasible in a low resource setting. I think that is a good move coming from NCCN, resource-based treatment guidelines. What is your comment on that, Ranjit?
So, so it is, the thing is, so I'm telling you a story about this Bayer thing. I mean, they made this drug called as sorafenib. Now, sorafenib, it causes a bomb. As of today, even the sorafenib which is manufactured by Bayer, it costs close to 1 lakh in a month. While the same generic in India, it is costing you 4,000 to 5,000. Now, till the time we are able to make generics, it is, these are life-saving drugs. So when it was proposed to Bayer to reduce the cost in many countries where these generics are not available, the CEO of Bayer, he told that we are making drugs for our own country, our own patients. We are not making drugs for other countries. Now we should take that thing very seriously, sir. We need to do research which is favorable for our patients. So, for an example, let me just tell you, if we prove that abiraterone 1000 milligram a day is as good as taking abiraterone 250 milligram daily with low fat, and we do the best study and prove it in a randomized fashion, what would happen is the drug companies will make the same cost for 250 milligram. So it refutes your approach to address this sort of trials. So we should do more feasible like trials, go for PK. In this study, what we have focused on pharmacokinetic mechanism. Now, when we look into the pharmacodynamic activity of such cases, maybe even 250 milligram giving with low fat diet daily could still be a higher dose, and the doses could still be modified to maybe twice a week or even once a week. So these sort of trials, the big pharmas are not conducting, and these are the need of the hour for low middle income countries. Now, at least as of today, there are only two drugs which are made by, which is recommended by NCCN. One is seritinib, as I told. The second one is abiraterone. Now, when that move was actually made by NCCN, they hiked their prices for 250 milligram OD. But then they went on to the superior authorities, and that move from the big pharma was actually been taken care of. So as of today, because India doesn't have a drug development this thing, so when we are using the drugs which are developed in the West and we are using it in India, we have to find our own way, our own pharmacokinetics, and looking into the pharmacodynamics and reducing the dose. That would be very paramount. I would also say if we are not doing in a scientific way, it becomes controversial. But when the patients are dying with the tablets or injections at the shelf, it doesn't solve the purpose.
Issue came with Herceptin. 1 year versus 6 months versus 3 months. It was not affordable when it was launched. How many breast cancer patients we have lost because of non-affordability? Despite evidence available for 6 months equivalence, still there is a lot of reluctance to come back to shorter duration regimes. So I think it is both ways, not only big pharma. The clinicians also have to look from a different perspective.
As of today, the way this country functions, more than 99% they have financial toxicity. Even if I have to pay 5,000 for me for my health in a month, I'll be undergoing that situation. So more research, in my opinion, should be conducted to bring down the cost. We are not experts to actually detect financial toxicity, but as of today, I think this is the mandate for even us to look into the patients.
No, but we are not, but we face that every day in the clinic. When the patient comes and cries in front of you,
Yes.
it is you who is going to handle that part, the financial part.
And at least in this patient, God had been kind so that he is alive for 5 years. So this sort of things, they actually work. Thanks, sir.
Good afternoon, everybody. Now we are from the on behalf of surgical oncology. We welcome you all once again, and we are going to present one of our novel techniques, HITAC, in stage 4 ovarian cancer. So our senior resident, Dr. Maddy, will present the case scenario.
Good evening, respected teachers and dear colleagues. Greetings from the Department of Surgical Oncology. Today's combined clinical rounds topic is hypothermic intraoperative thoracoabdominal chemotherapy, which is a ray of hope for advanced ovarian malignancies. Now, the incidence of ovarian malignancies has been increasing from time to time, and for advanced stages, the prognosis continues to be dismal. The majority of our patients still continue to present with advanced stages, more so in our own very institute. The incidence of CA ovary, according to Globocan 2020, has been approximately 3.4% of all the malignancies detected, and the mortality has been 4.7%, which is very significant. With the advent of HIPAC, the 5-year survival has increased. I would like to quote two articles specifically in this case. The first one being by Vandriel et al., which was funded by the Dutch Cancer Society, published in the New England Journal of Medicine. They showed improvement in both overall survival as well as disease-free survival considering HIPAC. The second one is the recently published JAMA article by Lim et al. From Korea, which looks after survival after HIPAC in primary and interval CRS, and they showed improvement in OS as well as progression-free survival following HIPAC in an interval setting. However, despite all these factors, there is a high chance of recurrence. The issue right now that we are concerned in this CCR is stage 4A patient, which includes malignant pleural effusion. Due to the presence of effusion, there is always a high chance of recurrence, especially when not intervened by anything apart from systemic chemotherapy. Now, hyperthermic intraoperative thoracoabdominal chemotherapy is a novel technique. It is a step to push towards a more curative option, and the challenge for the same exists for both the surgical oncologist as well as the anesthesia team. We are the first, as per literature, to perform a series of HITACs safely in stage 4A patients in our institute. And today we would like to share our experience along with the anesthesia team. The outlines of this presentation includes the clinical details, the neoadjuvant treatment taken, the anesthesia perspective, and the surgical technique, followed by review of literature. I'd like to present a case of a 55-year-old lady, a resident of Uttarakhand, who presented with increasingly vague symptoms of abdominal pain and associated with heaviness and fullness for about 5 months, with a more recent onset of shortness of breath and right-sided chest pain with discomfort for about 1 month. She did not have any comorbidities. She was postmenopausal and with no significant family history of malignancies. She did give history of disturbed sleep and loss of appetite. At presentation, she had a poor performance of ECOG score 2 with poor nourishment. On systemic examination, there was gross ascites with a ill-defined vague lump palpable in the pelvis. The per rectal examination also did show presence of pouch of Douglas deposits. There was presence of pleural effusion on the left side, which made breath sounds reduce on the left side, along with dull note on percussion. The preliminary investigation showed that there was raised CA125 with gross right pleural effusion, as we see on the X-ray. The initial CT done at presentation showed presence of gross right-sided pleural effusion, along with pleural deposits and thickening of the diaphragm, thickening along the diaphragm, both on the pleural and the peritoneal aspect, with presence of omental mesenteric deposits, along with bilateral tubo-ovarian masses. The important investigations to help us prove the diagnosis was the omental biopsy, which showed presence of high-grade serous adenocarcinoma, along with pleural fluid cytology, which was also positive, and pleural nodule biopsy, also positive for adenocarcinoma. Apart from which, the other investigation were more or less towards normal, and the PFT showed severe restriction. The final diagnosis that was made was carcinoma of ovary with right pleural effusion, stage 4A. Now, in this setting, there were several options that we could look forward to, including primary cytoreductive surgery followed by systemic chemotherapy, NACT followed by interval cytoreduction, with or without addition of chemotherapy, either intraperitoneal in the form of HIPAC or EPIC, and HITAC, which we are discussing today. Based on the MDT discussion, final plan was made to be neoadjuvant chemotherapy and assessment for interval cytoreduction and HITAC. There were several factors that were taken into account while planning this. Prehabilitation for surgery started 4 weeks prior to surgery. The patient received 3 cycles of chemotherapy, and following which she had symptomatic improvement. Her ECOG performance score became 1. However, there was still the ascites had reduced. However, there was ill-defined mass still palpable in the pelvis and in the upper part of the abdomen, with decreased air entry on the right side. The CA125 had decreased slightly. The following which the imaging done prior to surgery showed presence of the pleural effusion being decreased. There was still persistent thickening along the diaphragm, both on the peritoneal and pleural side. There were mass-like lesions present posterior to the liver, along with primary response in the partial response in the tubo-ovarian masses. When the patient was taken up for surgery on exploratory laparotomy, this was the finding. There were bulky tubo-ovarian masses present bilaterally with pelvic peritoneum appearing normal. However, there were presence of multiple retroperitoneal lymph nodes and pelvic lymph nodes. With thickened parietal peritoneum, there was presence of deposits, large deposits in the omentum, the liver surface deposits, and subdiaphragmatic deposits. Now, the important point here is that subdiaphragmatic deposits were transmural and involving both the sides, pleural and the peritoneal sides. The PCI for this patient was 15 out of 39. There was hemorrhagic pleural fluid and presence of miliary pleural deposits. Now, further discussion regarding the anesthesia perspective, I would like to invite Dr. Rakesh Garg, who is an additional professor in Department of Onco-Anesthesia. Thank you, sir.
Thank you so much. Thank you, Dr. Dev and Dr. Amdi Ray for this opportunity. So when we talk about the combined procedure, we do not have a very robust evidence, and many of the things are upcoming with regards to the HITAC procedures. This is with regards to temperature regulation, the use of specific technique for anesthesia, various type of fluids and their strategies to use them, and the use of albumin supplementation and the airway management. They are still controversial with regards to that. We do not have a standard protocol because this is relatively new procedures. Since hypothermia is one of the required entity for it for bringing about the effect of the procedure itself, but this temperature homeostasis is quite challenging, specifically through three phases. During the cytoreductive phase, there is always a risk of hypothermia, which causes a lot of issues with regards to the various changes in the body physiology, and we try to maintain it using various procedures like force air warming blankets and foam infusions. During the HIPEC phase, intrathoracic and intra-abdominal, there is always a risk of hypothermia, sometimes the temperature shooting up even up to 42 degrees Celsius, and it do brings about a lot of physiological changes with regards to various body systems, including cardiovascular, respiratory, and metabolic as well. During the post-HIPEC phase, again it becomes challenging because there will be a fluctuation from hypothermia back to hypothermia. And again, we need to require to maintain the temperature. So there will be a lot of fluctuation of temperature that happens during the whole procedure. And that's why this temperature cascade will bring about physiological changes in the body. Similarly, the fluid management is also not uniform throughout the process. The cytoreductive phase, there will be an extensive loss of fluid and blood as well. And that's why we target a urine output of acceptable limit of 0.5 ml per kg per hour. But during the hyper phase, because there will be an effect of not only the hyperthermia, but also the chemotherapy effect will be there on the renal system, and we need to have a well perfused kidney. We try to maintain a urine output of 2 to 4 ml per kg per hour in these patients, and that needs to be continued in the post-HIPEC phase because there will be some residual effect on the kidney functions. In addition to various cardiovascular changes, we still target urine output of 1 to 2 ml per kg per hour for these patients. Now, when we talk of the HIPEC procedures, there would be a lot of respiratory changes that will happen. There will be increase in the partial pressure of carbon dioxide. There will be decrease in the arterial alveolar gradient, and pH tends to be lower in these patients. Similarly, to mitigate these effects, we need to bring about change in the ventilatory strategies for our patient so that the respiratory component is taken care of. Similarly, in isolated HIPEC phase, there will be change in the cardiac function, especially during HIPEC phase, which is in a hyperdynamic state in which there will be increase in the heart rate, increase in the mean arterial pressure, increase in the central venous pressure as well. Hence, we have to be a little cautious in these patients that these patients are getting perfused for various organs, specifically the kidney functions. But what actually happens is when we start the HITEC phase, the combination of intra-abdominal and intrathoracic, these physiological changes are further precipitated. Say, for example, in the cardiovascular system, when the fluid is being infused into the thoracic system, there will be obstruction of SVC and IVC that will further decrease in the venous return and the cardiac output will go down. There will be direct cardiac compression because there will be increase in the intrathoracic pressure because of the perfusate itself, and that will again further precipitate the cardiac output reduction. Also, there will be increase in the myocardial wall tension and increase in the heart rate, and that will increase the oxygen demand, and that is over and above the increased metabolic rate because of hypothermia. So these all will have some impact on the cardiovascular system that remains very challenging to maintain homeostasis. With regards to the respiratory system, what I mentioned about the HIPEC phase, what things are exaggerated is there will be increase in the intrathoracic pressure. There will be shift of the mediastinum towards the other side that will further aggregate the increased airway pressures, and there will be reduction in the functional residual capacity also. So this means we are going higher up for loading our lungs with more pressures with reduced capacity. Hence, the chances of physiological changes leading to pathological harm to these systems are always there when we start looking for the combined approaches. We have published these challenges earlier also, and what we have realized comparing a HIPEC phase, there will be an addition of the cardiovascular changes, which I just mentioned. There will be increase in the respiratory morbidity with regards to the increase in intrathoracic pressure and mediastinal shift. And in addition, there will be additional exaggeration of the other body system, like for example, say coagulation derangements. The hypothermia followed by hyperthermia, both are cascades of coagulation derangement. This will be further aggregated if there is a combined approach. Metabolic and electrolyte derangements happen. One of the biggest issues is the occurrence of metabolic acidosis that may persist for 6 to 24 hours. And because of the decrease in the perfusion, because of the cardiac function and the renal function, the lactate levels goes even up to 10 millimoles per liter. And these are the factors which has been considered as one of the independent predictors of the morbidity and mortality after these procedures. Similarly, the postoperative complications and additional complications when we go for the HITAC procedures, because when this hyperthermic chemotherapy is circulated into the lungs, it also causes direct toxicity from both the aspects, the hyperthermia as well as the chemotherapeutic agent, and that leads to increased chances of empyema, air leaks, bronchopleural fistulas, and pneumothorax. And this requires the airway management strategies, important challenge for us, because airway pressures are high, the lungs becomes more friable and fragile during the procedures and after the procedures. So the mechanical ventilative strategies has to be changed from a standard conventional strategy to a lung protection strategy, so that these type of complications are not seen in these patients. The fluid management, as I mentioned in HIPEC strategy, it is important because we have to maintain the perfusion of the kidney and other vital organs, but simultaneously when we are going for the HITAC procedures, any extra amount of fluid that is being given to these patients will lead to more amount of already damaged lungs because of the hyperthermia. And these patients becomes more at risk of having alveolar damage, interstitial edema in the lungs, leading to further increase in the airway pressures. This mandates implementation of hemodynamic monitoring also, because the hyperthermia and direct impact of perfusate into the thoracic cavity mandates to use advanced hemodynamic monitoring for these patients, so that neither we are underfilling the heart, not we are overfilling them. And that challenge is always there, that what is the right fluid. And we do not have an exact monitor or a standard monitor which can give us the exact amount of fluid or a target hemodynamic target that is being used for these procedures. So what we need to do is we need to have an adequate fluid therapy that needs to be individualized for each patient, a careful filling of the thoracic side, keeping a target on the cardiac output by the advanced cardiac monitoring that we are using, the cardiac output monitor. We also look for the airway pressures, that we are looking that there is no thoracic mediastinal shift that can lead to compromise of the cardiac functions. And at times we also use catecholamines for these patients, because the direct lung injuries can be mitigated by suppressing the direct immune response to these agents on the lung itself. And hence sometimes it is used, but we have to be cautious, because catecholamines have their own side effects, like increase in the blood sugar levels, and they also decrease the recovery from the wounds that these patients have. Also, we need to remember that these procedures are extensive. The pain is always a big issue in them. If the HITAC procedure is being done through the thoracotomy, they will have a lot of pain, not only from abdominal area, but also from the thoracic areas. And hence we are taking care of using multimodal strategy for pain management. One lung ventilations remains an issue, because one lung ventilation mandates having high pressures, which is being compromised because of the perfusate in one of the thoracic cavity. Hence the one lung ventilation remains challenging. Maintenance of normothermia, because the surgical exposure of the tissues are very high. Risk of coagulopathy because of the multiple aspects that I just mentioned. The renal dysfunction, dyselectrolytemia, and hyperglycemia. These again requires continuous monitoring of the patients so that these do not lead to increased morbidity and mortality. And that's why these patients require monitoring, a strict monitoring at least for a day to two, so that these complications can be taken care on time to decrease the morbidity and mortality. So I'll hand over to Dr. Amdire for the surgical technique.
Thank you, Dr. Rakesh, and not for supporting here only, all the time supporting the OT also. And so as far the surgical technique is concerned, this is definitely a challenging approach, no doubt about that, but quite feasible like this. But we know we adopt this extraperitoneal approach, because after NSCT we don't know where the disease was there exactly, and NSCT given because of the extensive disease. So our approach is always extraperitoneal in view of the removal of the total parietal peritoneum. So apart we all know the CRS we always use to THBSO, bilateral PLND, RPLND, total greater romentectomy, lesser romentectomy, and organ resection as per the requirement to achieve the CC0, or I mean optimal site reaction. So in this case, we have only resected the hemidiaphragm, right-sided hemidiaphragm, because that was totally infiltrated. And for this why we have to mobilize total liver. So that is a special technique. Total you have to mobilize so that the liver will hang on the IVC only. And we did this thing to achieve this hemidiaphragmatic resection. So this is our HITAC set. You all know about this thing. Those who are in our OT, like we open always adapt this semi-open technique, and we use this cisplatin for this ovarian cancer, 75 milligram with NS perfusate in 2.5 liter, 41 to 43 degree centigrade temperature for 1 hour, and our flow rate is 1 liter per minute. So this is our a technique, the liver mobilization technique. Because of short of time, we can show these things slightly, because this thing, because special technique how will you mobilize the liver, because that's a huge disease was there. We have to separate the disease. We remove the falciparum, we cut the falciparum ligament, superior coronary ligament, inferior coronary ligament, and right triangular ligament. And that is very important aspect to know these things, because the suprahepatic IVC, you know, because that is from the central tendon. The suprahepatic IVC is just 2.5 centimeter within the from the central tendon. You have to take care about that, and just below that the right hepatic vein drain into the suprahepatic IVC. So that part is very important, and the most important thing is that you have to separate the total diaphragm in the, to resect the diaphragm. So that is also important thing is there. So this is normally that one technique is there, how to do the liver resection, how to do the liver mobilization to resect the diaphragm. Even the peritonectomy, you have to total mobilize the liver. So these are our specimen. You can see this thing. This is the abdominal side of the diaphragm. This is the pleural side of the diaphragm, and there is a big hole is there because that already automatically created. That good for the HITAC. We didn't have to put another effort to create this for the HITAC. So this is our ultimately the set of the HITAC. So that is in between this in combination of the HIPEC and HITOC. So this is our semi-open technique we usually adopt. And this is this thing after HITAC, we see this is the rent of this diaphragm through which the drug perfuses into the pleural cavity. And ultimately we just reconstruct this thing, that diaphragm with the proceed mesh as usual. So these are our, after the reconstruction of the diaphragm with the proceed mesh, you can see this. And so the operative details you all know. In this case, apart from the routine steps, we did this total right diaphragmatic resection to achieve the optimal site reaction. And the diaphragm was reconstructed with the mesh with the Prolene. We use the Prolene 10 suture, and that surgical time totally takes long time in the CRS, but it takes 8.5 hours. And blood loss around 1.2 liter. That is always the controversy there. We surgeon says blood loss is 1 liter, 1.2 liter. By anesthesia colleague said, boss, it's more than 2 liter. So it happens. It's a pleasant tussle all the times with the anesthesis. So that thing happens, but they manage very nicely. So this is the post-operative picture. If you see this thing, we clean this. How we clean this total pelvis, total we dissect the all pelvic nodes and RP nodes also, that we routinely do in ovarian cancer, particularly in advanced stages. So these are our specimen. Particularly in this specimen, I remember I just sent around 28 specimen to the pathology department. I got a call from the pathologist. You send always 20 specimen. This time 28 specimen. So we did a special thing. So we already convinced them. So these are our total specimen. Around 28 specimens are there. So post-operative course was usual. That is luckily that you can say this thing wind of the ventilator from the second post-op day. And thereafter some renal function derangement, liver function derangement, coagulation derangement was there, but that was managed conservatively because of the anesthesia team. They are very much like expert in this, and particularly in the ICU settings. And on second post-op day onwards, we started walking and mobilizing the patient and started ambulating, and post physiotherapy, spirometry, all the things are normal. And luckily we discharged the patient on the post-8 post-op day and very stable state. So histopath report was the same because already we did have the biopsy because the high-grade cyst adenocarcinoma. So there are multiple deposits are there. The rectal deposit, laser momentum, mesocolic deposit, all the positives are there. So extensive disease despite of NSCT. So the nodes are also positive, pelvic nodes and retroperitoneal nodes. Pleural deposits already the features of adenocarcinoma was there. So last follow-up, the luckily that patient after 21 months the disease free. So that is we can say our achievement in stage 4 ovarian cancer. So this is review of literature. That is very important part. If you see the Sugar Baker, the pioneer of CRS and HITAC, the Sugar Baker, he published the first paper on particularly the GI cancer, in particular pseudomyxoma peritonei and peritoneal malignant peritoneal disease, mesothelioma. So he says that is a quite feasible technique. I say no problem is there, but he shows the adverse effect, means that morbidity, the grade 3 and grade 4 morbidity around 43%. So that's a very high, 43% morbidity is there in his cases, particularly he is a very experienced surgeon. And but he says the HITAC in that survival was acceptable in this, and the incidence of intrathoracic recurrence is low. Because stage 4 disease, when the pleural effusion is there or pleural deposits are there, chance of recurrence is much more higher, because he performed this in the GI cancers when the diaphragm he resected, and he shows that recurrence rate is low in thoracic. And that is our paper only available that time when we published our paper. So we did in the, even he shows this thing, that is a very nice thing, and he shows both the drug he used, one is the mitomycin and another is doxorubicin. He says the pleural cavity, the absorption is less. If you see this from this graph, the pleural cavity absorption is less. So where the drug absorption is less means that exposure to the tumor is more. So that's why I think the pleural recurrence is less here. So here also this is depicted this. And apart from this, we have found another case report from one gentleman in the stage 4 ovarian cancer. He performed the same technique, HITAC is this thing, and he says also the same, but this paper is after us. We have published our first paper, I will show that. And he says this is the reasonable and feasible option for the patient and for the short-term outcomes. And the full thickness of the diaphragm infiltration and pleural effusion, this is one of the options for the patients for the better outcomes. So this is the comparison of the HITAC and HITAC. We all know HITAC for the last 2 decades, the HITAC is struggling, I can say, till date. And for last 1 decade, it was struggling because of the high morbidity, particularly in scenario like in India. Patient is not that up to mark as per the nourishment is concerned. So there are so many complications are there. Even if we see the literature in Indian patients, 20 to 40% complications were there. And our complication rate also in the early stages, they were very much high also, and the same thing ultimately we reached to the international level after a few years. So these are, apart from this HITAC complication, you all know DVT, paralytic ILS, blast abdomen, so many things, lymphocyte, ureteric injury, so many things are there. Apart from this, when you do the HITAC sort of thing is there, apart from so many complications added, pulmonary edema, already Dr. Rakesh mentioned about that, pulmonary edema, cardiomyopathy, cardiotoxicity, intestinal pneumonitis, and so many things are there. A lot of lists are there, but we experience almost everything in this, but we manage the patient nicely. So this is our publication. I say about this. This is our first publication about the technical description we mentioned about this. But CRS that HITAC is a complex but evolving procedure definitely. When we thought about that in stage 4 disease, when the pleural effusion is there or pleural infiltration is there, what could be the best option? If you give the chemotherapy, chance of recurrence is there. Then we thought Sugar paper was there. He used in the same technique in the GI cancer. So we use first in the ovarian cancer also. And we feel there is no life-threatening surgical morbidity was there during the surgery. There is no mortality was there. And CRS HITAC can be safely performed and replicated easily, I think, without any additional resources. So we can do the same way. Only we created this, we resect this diaphragm, and same we just put the same HITAC solution, same chemotherapeutic drug, and perform the HITAC. So this is our the series all thing. This is the 4 cases we published, 4 cases the series, and that published also. And there is the same thing we seen this thing. There is no morbidity was there, not mortality was there, and everything is stage 4A ovarian cancer. Definitely that requires a combined multidisciplinary team. Without team, that is, we cannot do this kind of challenging procedure. I say the peritoneal disease needs adequate local treatment like CRS and HITAC. We know this thing, HITAC we are doing in the for the abdominal cavity, and for the HITAC that is, I feel that is a reasonable treatment option for the ovarian cancer with the malignant pleural effusion, even the pleural deposits. So CRS with HITAC and HITAC needs that is collaborative surgical team and anesthetic skill and effort. There is no doubt about that. On the passage of time, on experience, we could reduce the morbidity, no doubt. So this is our technique. Already we mentioned about that. We did in the 4 patient. We seen the result without any significant intraoperative complications. We see that morbidity is also acceptable. We conservatively manage all the patients. So from our conclusion from this paper, that HITAC is effective and safe therapeutic option for the recurrent stage for the stage 4 ovarian cancer patients. And that is that at least you can see the our patient, we can see the respiratory distress was there, and patient was not so much stable because of the respiratory distress that was there. But after this, the patient condition was stable and symptomatically patient improves because of the reduction of the respiratory distress level. So this thing is there, but we just the much follow up is required to see the recurrence pattern in such novel technique. So this is our take-home message, like CRS and HIPEC. I mean, both the combination that HITAC is a complex and challenging procedure, but that is a viable treatment option for the stage 4 ovarian cancer, no doubt, with the curative intent. Because otherwise there is no option you can think about that can cure that stage 4 disease. So patient selection is very important. You always say our HOD, the biology is the king and selection is the queen. Selection is the queen. But truly speaking, in our center, particularly in tertiary center, particularly AIIMS, we had heart bound and hand is bound to select the patient. Almost all the patients come for the last hope. We have to take the patients like this. So that is one of the good options for this, and I believe the teamwork is the key for the success. That is always there without any doubt. And our initial experience has good therapeutic procedure. We believe this that is a good therapeutic procedure for stage 4 ovarian cancer. And definitely we need the further research and multiple patients. Then we can say this thing and long follow up to assess the therapeutic efficacy of HITAC. So that is our initial experience we share here, with a particularly emphasizing on one particular case. So thank you very much. But I feel like a long way to go. We have to research on that. Thank you for the patient sharing. Thank you, everybody. Sir.
Basically, for those who are not from the oncology or medical oncology field, there is a paradigm shift in the management, as Dr. Ray has highlighted, for the peritoneal and pleural diseases, which were considered inoperable and incurable. Last 10 years, there's a paradigm shift. Now it is become standard of care, intraperitoneal hyperthermic chemotherapy for ovarian. And I'm proud to say our department is one of the largest volume departments for HIPEC in the government sector. We are touching almost 300, Dr. Ray, right now, I think, for ovarian, almost 300 cases. So Plura, I think this is the new advancement we are trying, Dr. Ray and Dr. Rakesh. So a small subset of stage 4 patients, we can attempt curative sort of treatment. So that is what we are looking at. So I think this is surface malignancy. This is not like a stage 4 parenchymal malignancies like lung and liver. That biology is different. So there is a subset which can benefit from these kind of approaches. So I would like to congratulate the team, Dr. Ray, Dr. Rakesh, the entire team, and we can take up any questions and answers, please. Thank you.
Thank you, sir. So 8 total till date, 8 cases, 8. So that is so that is in the sugar paper. If you see this thing, he says that is the less exactly. But in our patient, that is our few number is limited. You know, that patient we did the HITAC initial patient we presented here. In 21 months there is no recurrence. But one patient had after 1 year the recurrence is there. So for the few limited patient that we cannot say what is the recurrence pattern. But if you see logically and scientifically, that is because we cannot put this thing as a paper or as a statistical data, we cannot put here because the less number. But if you think logically, suppose stage 4 disease, when the pleural effusion is there, and suppose that pleural deposits are there, so the chance, I mean, after the chemotherapy, particularly when there's some kind of response is there, until unless you remove with this, so chance of recurrence is much more higher. Even in the peritoneal cavity, if you say despite of giving neoadjuvant chemotherapy, 70% recurrence is there within 5 years. So that kind of thing we are doing something like logical, but it's still to prove like this way, that I can say. No, this is, clear cell is another aggressive variety. Like this in mucinous, there is no chemoresponsiveness is there. So that's why that mucinous mainly in the pseudomyxoma peritoneum, because that is the standard, the HIPAC is standard for pseudomyxoma peritoneum, because there is no alternate way of treatment, because the chemotherapy chance of chemotherapy response is very less. So that is for 4 to 24%. So in that case, without any doubt, you have to do. There is no other option are there. But tell me, clear cell definitely that is very rare disease number one, and another that is also the less responsive to chemotherapy. So there is the HIPAC role of HIPAC and HITAC is definitely there. It means something is better than nothing type. So I cannot say that is the standard thing is there. But when there is no other choice, then that becomes the choice. That is the thing. So like in the pseudomyxoma, same thing is there. Pseudomyxoma chemotherapy response is less in systemic chemotherapy. That's why it has become the choice. Like. No, that is the sir is telling like this because that biology is altogether different. This is a contiguous involvement is there in the pleura from the diaphragm. So that is altogether different entity. The biology is aggressive. So that's why it doesn't act like this.
Yeah, parenchymal is totally different ball game. What we are talking is surface disease. Especially we need to extrapolate the concept of mesotheliomas, where we do a pleurectomy, then add this. So ovary is just extrapolation of that same concept. So now we are trying intrathoracic part, but we are not adding any pleurectomy to it. So only surface malignancies, there is evidence, but intraparenchymal and all is totally different ballgame. There, I don't think HITAC and
Right, sir,
others will work. But if it's a solitary lung met, solitary liver met, again, a metastectomy is a different situation. So if you have a complete ovary with one intraparenchymal solitary lung metastasis, of course, literature is not there, but you can go for a solitary lung resection, wedge resections or something.
That's why in that case we do the stage metastatectomy like this way. So to achieve the R0 total. No, that is not that. Because of that thing, that is only indication this from our side when the patient GC is not good. Patient cannot tolerate this kind of long surgery, 8.5 hours. So that is one of the important criteria I believe like this way. Otherwise, suppose this kind of cases we can go for this thing in primary settings also we do the CRS. But that see this which patient can tolerate that thing. So patient usually our patient more than 50% patient and the GC is poor. And why should you go for this thing unnecessarily, just add the morbidity like this, doing this kind of long surgery? So for that way, most of the patient in our scenario is sent for the chemotherapy, then we go for the surgery. Yeah. That is it.
So one of the principles for peritoneal disease also, you should be able to remove all gross disease. So here pleura is normal, but there is effusion, which is malignant effusion. So this chemotherapy hyperthermic is likely to work because there is no gross disease nodules. Yes. No, not here, because here in the ovary we are only perfusing the thoracic cavity, because the route of spread for ovarian cancer is the transdiaphragmatic lymphatics. The malignant cells go and cause malignant effusion. So there may not be nodules. So once you do a laparotomy and communicate both abdominal and thoracic cavity, it is like a single serous cavity. So if you are perfusing this, you can as well perfuse the thoracic cavity and may get some benefit. So that is the concept.
So there is no question that the time is more. Today we got extra 5 minutes because of medical oncology. Thank you very much for the kind presence. Thank you everybody. Thank you.